So this is the torsade de pointe, and these are polymorphic ventricular tachycardia. Basically, you'll see a lot of very quick heart rate shifting sinusoidal waveforms. ECG sees a lot of shifting, and here you'll see an example of that, rhythmic in a sense of sporadic, but also in a characterized waveform. They're going to be together, but then they twist around in a sense, twist around into different amplitudes of heart rates. It can progress to ventricular fibrillation. Don't forget, VF can migrate and have myocardial infarction if not treated. Long QT intervals predisposes to the torsade de pointe. Caused by drugs. You have a decrease in potassium, a decrease in magnesium, congenital abnormalities. Treatment on the exam, make sure you know this. This is magnesium sulfate. That's what you're looking for on the exam. Drug-induced long QT. So again, the Q point to the T, A, B, C, D, E. That's the way to remember this. Antiarrhythmatics, class 1A and 3. Antibiotics, marcolides. Anti-C, psychotics, haloperidol. And antidepressants like TCAs, antiemetics, ondansetron. Torsade de pointe, twisting of the points. That's the way to think about it. And this is your example. Congenital long QT syndrome, well, slightly different, inherited disorder of myocardial repolarization. See these words, myocardial repolarization. Here you're going to see due to ion channel defects, increased risk of sudden cardiac death. Due to torsade de pointes includes Romano-Ward syndrome. This is an autosomal dominant pure cardiac phenotype. No deafness, though, is prevalent. You also have the Jervell and Jang-Nielsen syndrome, autosomal recessive, sensory neural deafness as well. So these are disorders that are inherited, consistent with torsade de pointe, and you'll have those as well. Brugada Syndrome, autosomal dominant disorder, most commonly in Asian males. So on the exam, you'll have, they'll tell you it's an Asian male. ECG pattern of pseudo-right bundle, branch block, and ST elevations. Increase in risk of ventricular tachyarrhythmias. And SCD prevents SCD with implantable cardiovertical defibrillator. Wolff-Parkinson-White syndrome, most common type of ventricular pre-excitement syndrome, abnormal fast accessory conduction pathway from atria to ventricle, like the bundle of Kent, bypasses the rate-slowing AV node. Ventricles begin to partially depolarize early. Here they're early. There's no dip in a sense. Shortened PR interval, PR. Remember, this is your Q down here. Characteristic delta wave with widened QRS complex and shortened PR interval on ECG may result in re-entry circuit. Then you're going to have a supraventricular tachycardia, so a little bit faster heart rate. ECG tracing. These are you're going to get these on the test, one or two of these. Atrial fibrillation, chaotic and erratic baseline. No discrete P waves. You'll notice there's nothing coming out in the front of these. They're kind of just jiggly, but they're not dipping or, rising in any way. Between irregularly spaced QRS complexes, now these are irregular, so they don't equal the same distance. So this atrial, IR, irregular. Think irregular backwards. Most commonly, risk factors include hypertension, coronary artery disease. Can also lead to thromboembolic events, particularly the stroke. Again, thromboembolic or just narrowing. Treatment includes anticoagulation, rate control, rhythm controls, and cardioversions. Okay. So that's what you're looking for in the description. Atrial flutter, rapid succession of identical, make sure you know these are different, identical back-to-back atrial depolarizations. Waves. The identical appearance accounts for the sawtooth. There's your sawtooth. Appearance on the flutter, so that's what the fluttering is. You see that. Treat like atrial fibrillation up here. Same treatment. Definitive treatment is catheter ablation. And then ventricular fibrillation. This is a completely erratic rhythm, and you notice it's all over the place with no identifiable waves. Can't tell what's the PQ or S or T. Fatal arrhythmia without immediate CPR and defibrillation, basically chance of success are low. AV blocks. This is where your PR interval is prolonged, greater than 20 milliseconds. Benign and asymptomatic, no treatments required, it just happens. Okay. And there's two types of second degree blocks. These are progressive lengthening. Here you have a similar, so notice they're equal here. That's first degree. Second degree, they're not. They're different until a beat is dropped. Now that's the key point. A P wave is not followed by a QRS complex. So here's your second P. Here's a P right here. There's nothing afterwards. There's no QRS. Variable interval with a pattern regularly irregular. So that's kind of what's going on there. Just look for something that's missing. They can also call that the Weckerbach. Mobits 2, always a popular question. Dropped beats that are not preceded by a change in the length. So here you have a drop with no change. So that's the easy way to remember. Here you had a drop with different changes. Here you have similar. And that's going to have a drop there as well. And then the third degree, a complete AV block. Here the atria and ventricles beat independently of each other. The P waves and the QRS complexes not rhythmically associated, so their atrial rate is greater than ventricular wave. Treated with a pacemaker. Can also be caused by Lyme disease. So here you see your P equal, and then you have a drop. So they're kind of independent of each other. Atrial natriuretic peptides. These are released from atrial myocytes in response to an increase in blood volume and atrial pressures. Acts via the CGMP, causes vasodilation, decreases in sodium rreabsorption. At the renal collection tubule, dilates afferent renal arterioles and constricts efferent arterioles, therefore promoting diuresis and contributing to aldosterone escape mechanisms. That's your atrial. And then also then you have the B-type brain natriuretic peptides as opposed to atrial. Here you have released from ventricle. That's the way to think about it. A is atrial, and B, or brain type, is ventricular myocytes in response to an increase in tension. Similar physiological action to ANP, the atrial natriuretic peptide, with longer half-lives. So BNP's blood test is used for diagnosing heart failure. Very good negative predictive value. Available in recombinant form, nesatiridide, and for treatment of the heart failure. And then we have this baroreceptors and chemoreceptors. Receptors here, the aortic arch transmits via the vagus nerve to solitary nucleus of the medulla. Responds to a decrease or an increase in blood pressure. Carotid sinus Dilated region at the carotid bifurcation transmits via the glossopharyngeal nerve to solitary nucleus of the medulla. It also responds to an increase and decrease in blood pressure. Baroreceptors. Okay. These are hypotension. Then you'll have a decrease in arterial pressure, hypotension, a decrease in the stretch, a decrease in afferent, barometric firing, and then you have an increase in efferent, sympathetic firing, and a decrease in parasympathetic stimulation. So you get a vasoconstriction, an increase in heart rate, an increase in contractibility, an increase in blood pressure from that. Important in the response to severe hemorrhaging. Carotid massage, you can do that with an increase in pressure on your carotid sinus, an increase in your stretch of the heart, an increase in afferent, baroreceptive firing, an increase in AV node refractory period, and then you get a decrease in heart rate. Components of your Cushing reflex, the triad of hypertension, bradycardia, and respiratory depression. Make sure you know that Cushing reflex, popular question. Increases in the intracranial pressure, constricts the arterioles, and therefore you get a cerebral ischemia, and an increase in pressure of the carbon dioxide. And then you get a decrease in your pH. So if you get a decrease in your pH, that's going to be acidosis. And then central reflex, increase in perfusion pressure, hypertension, increase in stretch, and you get a peripheral reflex baroreceptor-induced bradycardia, again, slow heart rate. Then you have this chemoreceptor, peripheral carotid and aortic bodies are stimulated by a decrease in your oxygen pressure of less than 60 millimeters of mercury. You get an increase in your pressure of carbon dioxide, and then you get a decrease in your pH of your blood. So just know that percentage oxygen and pH of blood are, they move together, and then the pH and CO pressure is inverse. Central, these are stimulated by changes in your pH and pressure of your carbon dioxide of the brain interstitial fluid, which is in turn influenced by your arterial carbon dioxide, which do not directly respond to your percentage oxygen. These are your AV nodes. As a side note, I just wanted to make sure you knew what efferent is carrying away. If an artery is in an efferent vessel that carries blood away from the heart, and an efferent nerve will carry impulses away from the central nervous system. And then, of course, afferent is carrying to or into. And so an artery is afferent with an A that carries blood to the heart. So that might be aortic. So that's kind of the way that difference is. All right. And finally, we have this last question, the last slide here for this normal cardiac pressures. Okay, it's the combination of all these pressures that give you a heart pressure in a sense. The percent of the blood and where they're located. It's a combination of weighted factors. Pulmonary capillary wedge pressure is a good approximation of your left atrial pressure. In mitral stenosis, your pulmonary capillary wedge pressure is going to be greater than your left ventricle and diastolic pressure. And PCWP is measured with pulmonary artery catheter called the Swan-Ganz catheter. Okay? So here you are right here. Your PCWP is a good approximation of your left. So right here. So your left atrial pressure would be right here.